My myth today that I'm attempting to bust is that midlines are unsafe for vasopressor administration. So just to start with, just to make sure we're all on the same page of exactly what a midline is. So on the left side, we'll see pictures of a bunch of different central lines, right? We're decently familiar with these and where they're supposed to end in the body. So we have mainly IJs, PICC lines, subclavians, some axillaries, and they all terminate in a large vessel like the IVC. And the midlines are placed on typically proximal to the AC and terminate also distal to the shoulder. And so those are typically placed, at least at Cottage in most hospitals, preferentially in the basilic vein, if not also the brachial vein or the cephalic vein of the upper arm. So looking at the midline kit that we typically use here in the hospital and the one that's typically used by the emergency department RNs that place these and who place the majority of our midlines, we have this kit called the PowerGlide Pro, and it looks and operates very, very similarly to the Aero kit that we use for A-lines, where it's a single unit that has the needle, the catheter, and the wire all loaded and can be placed in this device. And they're typically 18 to 20 gauge and have a catheter length of 8 to 10 centimeters. I think we also have these at Cottage too, but a lot of the nurses aren't certified or trained on this kit exactly. I think I've seen some floating around, but other hospitals seem to use this one as well, which is also a PowerGlide, but this one acts a lot more like our central line kit, where the wire, the catheter, are separate units, and the wire is much longer than the one in the preloaded set. So the thing I'll start with is just the current Cottage policy right now revolving vasopressor use and peripheral IVs, right? And so this is something I was talking to Bob about that it sounds like we started around 6 years ago, maybe 5 or 6 years ago. And as you know, we actually use these quite a bit. And so with the peripheral IVs, we're supposed to be putting a nursing communication order that we can use it for up to 24 hours. The peripheral IV can be only using one vasopressor. If we're using two, we should be having a central line here. You need to have two working IVs just in case one fails, so you can't be just running a patient with a single access point with a vasopressor through that. The sites that we're not supposed to use, and you've probably seen them being used in these sites, especially in the ED before anyways, but no peripheral IVs in the AC are supposed to be running vasopressors. They're not supposed to be in the hand. They're not supposed to be in the foot. And notably, you'll see in Part 9A, Part 5, that there's no use of midline catheters. We're supposed to also, I think, check the IV for blood return every 6 hours, and also to monitor and assess the IV site running the vasopressors every single hour for signs and symptoms of extravasation. These are the current Cottage policies on the doses that we can use. This is actually a surprise to me because I've almost never seen it really used up to the 0.3 dose for Levophed, but it looks like we can actually, technically under Cottage policy, do that. And then the rest of the doses, we used epinephrine, dopamine, phenylephrine a lot less, but Levo up to 0.3. Okay, and so I'm going to briefly breeze through the data around peripheral IVs and other centrals, just because that's not the point of this talk. But it looks like a lot of these Cottage policies changed when big systematic reviews and meta-analyses and other multi-center controlled trials came out studying the efficacy and safety of using a peripheral IV under different protocols and settings. And so I won't talk about it too much here, but it seems like overall, from a safety perspective, under the right conditions for the right people, it wasn't deemed completely unsafe to use peripheral IVs for temporary vasopressors or for low-dose vasopressors with typically low rates of extravasation, but lower rates of really, really major events related to extravasation, like limb endangerment, ischemia, necrosis, and so on and so forth. This next study was just to kind of show you guys the fact that when we're placing these central lines in folks, this isn't necessarily always a risk-free procedure. Sometimes it seems like if you've only been doing this for like 5 or 10 central lines, it's like this always goes well. I haven't harmed anyone. There's no infections associated with this. It's a largely pretty simple and easy procedure. But it's important to know in this New England Journal where they actually it was a randomized control trial randomizing people to different central lines in the subclavian, femoral, and internal jugular, and looking for complications of blood infections later on due to those, but then also from the initial placement of the line, mechanical complications. And so you can see from this one that with the subclavian, jugular, and femoral, when they talk about mechanical grade 3, which is those gray bars in those different sites, those are mainly driven during the placement. And specifically with the subclavian and jugular, those mechanical complications were pneumothorax due to that. That also included bleeding, poking arteries, and so on and so forth, with being the main driver of complications for these central lines. Also infection and DVTs. A lot of the studies I'm going to be talking about after this, they don't compare midline vasopressor use to central lines placed in the IJ subclavian and femoral. There are no studies that look at those two in comparison. Most of them are either retrospective reviews looking at just midlines and their safety and efficacy. If not, they're comparing them to midlines to PICC lines, which seems like a more equivalent procedure in terms of usage. So this first study, this one's not about vasopressor use, but just noting the fact that there's differences between midline catheters and PICC lines in terms of infection rate and DVT. And so when you look at this study, what ends up being the results of this, and you can look at the top bars, they ended up doing 10,000 patients that were randomly controlled to either a midline or a PICC, and then assessed for major complications, mainly including bloodstream infections, catheter inclusions, and also systemic DVTs. And so the takeaway that they had from this study was mainly that if you look at the second row, that bloodstream infections seem to be significantly increased in PICC lines versus midlines in a sample size of total 10,000-ish patients. Okay, so when we're doing these central lines, the theory has always been, hey, we're trading off life-saving measures, but also recognizing the fact that with these central lines comes a possible increase of infection. This first study is talking about the safety and efficacy of vasopressors through midline catheters. This was a retrospective study that was done between 2016 and 2019 at George Washington University. They had a sample size of 248, and this was at their 45-bed tertiary ICU in a 600-bed teaching hospital. And so the first thing to note is the left chart shows their average dose and maximum doses that they were running vasopressors through these midlines. And so 15, I don't think they broke it down into weight-based for the average dose, but 15 micrograms per minute for the average patient that's weighing, let's say, 70 to 80 kilograms is around 0.15 to 0.18 in our standard pump usage that we're used to seeing. And you can see that the maximum doses of Levophed up to 0.67 actually through these. And a lot like our center, on the right side, it's showing the characteristics of who is placing these. And so the majority of these are placed by a midline nurse who's trained and does these all the time. Otherwise, they look like they have some fellows and residents, and IR actually place some of these as well. A lot like our center as well. I don't have the data exactly on this, but this is just very anecdotal from seeing them and also talking to a lot of the midline nurses. Most of these go through the basilic. In this case, it was 98.8% in this study. For ours, it seems like that's the first vein that they're trained to target first. They'll try the basilic on right side and then go basilic on left side. And if it's still emergent, they'll start looking at the cephalic and then the brachial. Oh, and the average midline dwell time in this time was 11 days. So in the results for this study, which ended up, 248 midlines, the thing that we've always been concerned about in this hospital, at least when talking to staff, when talking to other physicians, has been when we're concerned about midlines in vasopressor use, we're concerned about the fact that if it extravasates and it's in a deep tissue compartment of the arm where we're not able to assess immediate leaking extravasation and would be late to the game on tissue necrosis and limb endangerment. And so a lot of the data I'm going to present is going to be focused around that point. So in this study, it looks like of the 248, one of them had a drug extravasation. One of them had superficial thrombophlebitis, and none of these ever, in the 3 years that they monitored these 248 patients, ever had a single patient that had in tissue necrosis, ischemia, or limb endangerment. It is important to note, though, that we did have 3.6% in this study of 6 patients having bloodstream infection that they attributed to the placement of this midline. Okay, and their conclusion was that it's kind of the myth I'm trying to bust, is that vasopressors are safe through a midline. Okay, it's a safe alternative to a CVC. So this next study we're going to talk about is a larger study in terms of number and power, but is a cohort study of 39 hospitals in Michigan from 2017 to 2022, where they infused vasopressors through a midline or vasopressors through a PICC. They also wanted to see the complications of just a patient having a midline in, but we're getting vasopressors infused from a different catheter, whether that was a peripheral IV or a PICC line, or a different central venous catheter. And so in this study, the primary outcomes were bloodstream infection, thrombophlebitis, catheter occlusion, and exit site infection. And they did 1660 patients. However, it is important to note that only 287 of these patients were getting vasopressors through a midline. When looking at this data, so in the highlighted part of the table, for extravasation, obviously not measured in the PICC line category. And when they're looking at the midline, we did have 2.1% of these patients have extravasation when they had vasopressors through a midline, and notably also 1.7 for just having a midline in general, which is that third column where it says midline N. Those are patients that had extravasation, had a midline in, were getting vasopressors, but not through that midline. They interestingly didn't even really consider limb endangerment in this study. It wasn't something that they discussed or talked about. Extravasation didn't seem to be actually the thing that they were mainly looking at. They were actually trying to study mainly the effect of thromboembolism and in the midline category. And so when you look at this category, when it goes to ipsilateral upper extremity DVT, meaning the patient ended up getting a DVT in the same arm that the midline was placed, there was shown to be a significant increase in the midline category above the PICC, and there was also an increase in the midline category with vasopressor use over the just having a midline in and running vasopressors at a different site. And I don't think I'm going to talk too much about these tables, but this is just the data being broken down into different catheters and different subgroup analyses. But overall, in terms of most of these analyses, there was no significant difference. As you can see, everything's crossing the 1 point here in any of these subgroups. So this next one is vasopressors also administered through a midline. This was the only study that actually had a published protocol on how their hospital manages midlines and has a protocol in place. And so this one was a single center prospective observational study from 2019 to 2020. And I think this one was done at Stony Brook. And their measured outcomes were bloodstream infection, tissue ischemia, limb endangerment, with minor ones of leaking, hematoma, ecchymosis, and DVT, but with a sample size of only 66. They always used a dual lumen midline, which I don't think we use here, that are cut to 8 to 15 centimeters. And a lot like we do here, their site selection involves evaluation of both extremities and the preferred site being the cephalic vein, if available. And so it's important to note that they have a protocol in place, and this is the only one that I could really find. And so the way that they did this, it was that they always, mainly on the bottom part, assessed the access site and checked for blood return every 2 hours with the midline infusing vasopressors. And so if the midline was able to flush but not withdraw blood, it was up to physician determination of whether or not we could still use that midline. However, if the midline could draw blood and flush, it was deemed safe to use. The main vasoactive agent that they used in this study, like all of these, is going to be Levophed at 95%. And the mean infusion rates will be noted on the right side. I found this part interesting because their mean infusion rate through this for Levophed at a weight-based dosing was actually only 0.04, which, is just very low. Okay. And in terms of individual vasopressor days, the average was around 3 days. When they looked at the primary outcomes, the most prevalent one was leaking, listed at 20%. But however, noted at these 66 catheters that there was zero extravasation, and in terms of major events at the very bottom, that tissue ischemia and tissue necrosis of these 66 was 0. And again, noted, like the similar study before, that there was around a 3 to 4% of ipsilateral upper extremity DVT at the site of the midline. This next study is from Sweden in what they call intermediate. It's kind of like a step-down unit is what it sounds like, but in their step-down unit, it's still able to administer vasopressors in Sweden. And so this one was from 2020 to 2023 and was a retrospective cohort study. Their primary outcome measures were extravasation of the vasopressor, catheter-associated VTEs, and also bloodstream infections. And in this category, in this study, they had 472 patients. And then here's just a breakdown of the demographics of patients, which is obviously not very similar to ours in terms of race, but very similar to ours in terms of disease processes. So in this study, any major complication was 2.5%. They only had one episode of extravasation that they were noted from all those midlines of the 472. And interestingly enough, when they had their secondary outcomes of midline outcomes here at the bottom, they had a high incidence of premature removal that in that study, they weren't able to exactly say what those were from in this retrospective study. And interestingly enough, too, they had 20% of these patients get a CVC after the midline. And they didn't put their protocols on what their maximum dosage ranges are, but it is important to note that they were only on an average running Levophed at 0.04. So I don't know when they determined in this protocol at this hospital that it was unsafe to run at a midline if they thought that and transitioned to a central line, because 20% upgrade to a central line seems like there's something in their protocol, at least to me, that made them think, hey, we need to place a central line now. And this one also concluded that having vasopressors through midlines had low rates of complications and that they'd be safe for vasopressors. These other studies that we're going to talk about have a lot smaller of a sample size. So this one was a retrospective review from 34 ICU beds at New York Pres between 2023 and July to December with a sample size of only 42. This was in a tiny little article, and all they had was just a methods and then this results saying of these 42, they didn't have any extravasation, infiltration, or injury associated with midlines and vasopressors. This one, again, also a retrospective review. And this one notably had midlines that were 10 to 25 centimeters in length noted. And again, when I was talking about ours are typically 8 to 10 centimeters in length. So that's an important fact to note here. But also another retrospective review over 9 months. And in this one, they also had no evidence of extravasation. In this one, I had 203 patients that were running vasopressors through a midline, but again, never noted the average dose, but in this one instead talked about the amount of hours that vasopressors were running through a midline. In this case, it was around 5,000 hours. And they also noted no extravasation, no limb endangerment and ischemia of these 203 patients. This one was I was debating whether to include this one or not because it had to be translated from a Chinese article in Chinese print. But that being said, this one again shows, this one was actually a randomized control trial that a Chinese study did. So, whether or not you believe in the harshness of their peer review process, but there is, in this case, randomized to 44 patients to each category of either getting vasopressors through a midline or through a PIC. And their primary outcomes in this case were catheter obstruction, infection, phlebitis, thrombus, but also didn't note a primary outcome in this one that they were looking at to be any type of extravasation or limb endangerment or ischemia. And the results of this study were that they didn't have a single infection or phlebitis, but notably just the fact that this study didn't even include a primary outcome being extravasation, I found that interesting. And so there's a lot of data there, but again, overall for these studies, none of these are giant multi-center studies. None of these are randomized controlled trials. However, I think it's fair to say that the myth is that midlines are completely unsafe for vasopressor administration. I don't think that that is completely true. I think that it looks like there's more work that needs to be done in establishing exactly what optimum safety protocols regarding midline vasopressor use are. I think there's more to look into about why there is an increased rate of DVTs when a vasopressor is administered through a midline as opposed to just having a midline in place, which it's been very well established that midlines in themselves are an increased risk of having a thrombus overall at that site. That's not new info. But for either temporary use or finding out exactly protocols in the exact midline that makes it safer is yet to be determined, especially if this hospital decides to adopt that policy someday down the road. But I think the myth that vasopressors through a midline is just completely and wholly unsafe, I believe is busted. And these are my references. Thanks, guys.
Are there any questions or comments from anybody? Dr. Seuss?
Have the kind of protocols for safety, and most of those papers you talked about that. What about the technique for placing? Was it modified Sullinger or one of the kits?
So just repeat the question and then answer it.
Yeah, so he was asking about how a lot of these studies, except one, didn't establish guidelines around safety, but asking the question that I've talked to Dr. Seuss about before, which is thinking about the different kits. And so all of them, the only one that talks about the kit is not the exact kit, but there's one study that was talking about using a catheter length of 10 to 20 centimeters, which only comes as the Sullinger technique kit.
Yeah.
And then the one that they were using at the Chinese study too. I always forget about the Chinese study. That was the last add-on to this. But in this case, in the one that had the established protocols, they were also using a dual lumen Sullinger technique kit. So in this one the only one that has established protocols did. And then the other studies didn't mention exactly what kit they used or the technique so much as they attributed more of the study to who placed the midline, which in all of these studies, over 90% of them was always a midline nurse. But that is an important thing to note that at our hospital, most of them are using the Power Glide kit, the all-in-one, and not the Sullinger technique with the external wire.
Other questions?
One observation, and maybe someone can correct me if I'm wrong. I didn't used to see hardly any midlines, and it was with the quality measure of central line associated bloodstream infections that all of a sudden we had access to midlines, and midlines were being placed as a preference. And of course, our central line associated bloodstream infections fell precipitously, and we are a high quality hospital. But based on the data you show here, it's the same more or less depending on which study you believe complication rate. It's interesting to see how hospitals quality initiatives that are maybe externally foisted on the hospital can sort of just drive care and have maybe unintended consequences. Or just be like playing three-card Monte.
Yeah, I think maybe Bob, Lauren, and Ashlock can speak more about this, but it seems like a lot of metrics used are central line-associated bloodstream infections, which you can't call it when it's a midline. And interestingly enough, even if there's not a difference technically between infection rates, let's say, theoretically there weren't, you would still have a lower incidence of that hit marker of having a central line associated bloodstream infections, even though you could have the same exact rate of overall bloodstream infection. It's just called differently in the metric. Does that sound about right?
Yeah. It's like the game.
Yeah.
It takes
Yeah,
So to your point, it sounds like
doesn't
yes.
necessarily prioritize patient care. External quality measures that are foisted on physicians and the hospitals that they work in, nurses as well, obviously, and patients.
Yeah, I agree completely. It's just gaming the system, basically. But the infection rate, at least, is not higher. In some studies, it was actually a little lower in the midlines, I think.
But maybe overall,
But so it may be a little bit better in terms of infection rates. But you're right. The CLABSI rate is going to be way lower if you're using all midlines or mostly midlines.
It helps pay the bills.
Yes. Yeah. The other thing, the only other thing I wanted to point out is a lot of these studies use 5 French catheters, and it looks like the catheter that we're using is 18 or 20 gauge. And I looked it up because I wasn't sure what a 5 French was equivalent to, but it's equivalent to a 16 gauge. So they are smaller catheters. Whether the rate of DVT or thrombosis would be lower with the smaller catheter, I don't know. It makes sense that it would, but I think there was one study where they broke it out to greater than 5 French or less than or equal to 5 French, but that still doesn't tell you that they were what the size was. But I would think that the smaller catheters in other venues, other things like PICC lines where you have triple lumen versus double lumen, there are more thrombosis and DVT with triple lumen than with the double lumen PICC lines. So I would think that would probably be similar in these, but we don't have data. Okay, well, that brings us to, if there's no other questions, so it's time to vote. Midline catheters are unsafe for vasopressor administration. How many people think that this is a true statement that they are unsafe for vasopressor administration? We have one, the pharmacist, notably, even after all this data. How many think that it's plausible? So we still have 4 or 5. And how many think this is busted? Looks like a majority think it's busted. So, all right, we're busted.